It's a complete pleasure to be here and to be in a room full of people who are interested in and enthused by the same things that I am. The program that's being rolled out now by the Medical Psychiatry Alliance is a really impressive one, and I'm genuinely honored to be here and to talk to you a little bit about some of the work that we're doing. So the way this is going to work is over the next 45 minutes or so, I'm going to give you an overview of the work that we have been doing in London. And I'm going to divide up what I'm doing into three. First bit, I'm going to be talking about why this topic is really important. Heard a little bit about it from the video, heard a little bit about it from Benoit as well, and I'm going to put my own kind of spin, and hopefully you'll understand the context that I'm coming from as well. The main bulk of what I'm going to be talking about is Maudsley simulation, which is this entity, this new department that we've set up in our hospital through in South London. And then what I'm going to try and do is give you a little bit of an overview of some of the courses that we've developed, and a few of the things that we are planning to do, and then kind of wrap it up at the end with a sense of where we're taking this going forward and how it links with our new partners here in Toronto. So I hope it makes sense, and you can see where we are. You'll get signposted at different points as we go along. So first up, why this subject is important for me. I suppose what I want to do is tell you a little bit about who I am, where I work, and why this aligns with so much of what we've heard so far today. So as Ladiger was describing, my main day job, about half my week, is that I'm a consultation liaison psychiatrist. Which means that I'm a psychiatrist, but work in the acute general hospital setting. So I've got a couple of photos up here to try and sort of describe this to you. I'm sure it's replicated right across Ontario and Canada as well. I'm employed by the Maudsley Hospital, which sits on one side of the road, and my office is in King's College Hospital, which sits on the other side of the road, divided in the middle by this usually incredibly busy road called Denmark Hill. For those of you who are aware, who know the services in South London, or go down to the IOP or the Maudsley, you'll know it well. I put a Google map thing up there as well to try and demonstrate Denmark Hill for you, because a couple of weeks ago I was out taking my phone, and it shows you what a rubbish cameraman I am, kind of going out into the middle of the road, trying desperately to take a photo of it so that I would have this beautiful metaphor of the mental-physical interface and all the difficulties that there are. Because the bulk of what I actually do is navigate patients across this road, backwards and forwards, between those people who end up having mental health problems in the acute trust and all the challenges that come about as a result of that, and then having to deal in the acute trust with everyone who ends up being admitted to one of our mental health wards, across the road over in the Maudsley, through in a care pathway that is as less rocky as possible over in the acute trust in King's College London. So I was out there trying to take a photo, and the reason it's not up there is all it came out was this kind of concrete mess. It could have been a road anywhere. I was wanting to actually sort of demonstrate something really clever, but it hasn't come out. But I was out there in the road, and one of my colleagues, who's an emergency department physician, just working there in A&E, because I was right outside it, basically is almost screaming at me as she's kind of walking out and saying, "I'm on call for trauma today. Get off the bloody road. Come on in. What is it that you're trying to do?" And as I kind of scurry back, I say, "Well, I was trying to sort of make a beautiful metaphor for the mental-physical interface." And she looks at me and says, "Metaphysical interface? Why is it that you psychiatrists always have to overly complicate things?" So leaving metaphysical stuff aside and actually concentrating properly on mental-physical, the reason that I want to tell you that story is because I think it is complex. It is incredibly difficult. These complexities are brought in by the way in which we structure our services and the approach that we take. But the person who's often obviously missing out most of the time is the patient. What I want to do is, before I come on to this, before the next bit, just kind of couch it in terms of a patient story that I was dealing with last week, just before coming over to Toronto. So, as I said, I worked for a couple of days, for half the week as a consultation liaison psychiatrist, and I came on Tuesday morning last week with an urgent call and a request to come up to the acute surgical ward. Often happens when I arrive, so I grab my intern and we head up to the acute surgical ward and find there a very harassed matron of the ward who's basically saying that there'd been an admission overnight that they find incredibly challenging. They'd had the on-call psych resident come along to try and do something about it, but they'd been a little bit overwhelmed as well, and can I please sort it out? This was a young woman who was 26 years old, who'd been admitted after a self-stabbing to the chest. She'd ended up getting a pneumothorax. It wasn't so bad that they'd needed to do anything about it at that particular moment in time, but it was something that they wanted to keep her in hospital for. And so I didn't even have to open the door. I arrived at the place where her bedroom was to find a degree of chaos there. We have the patient who is acutely psychotic. She's responding to hallucinations. She's misinterpreting things, and she's misidentifying people as well, such that this is driving her to actually clamber onto the windowsill and look out the window, shouting at her boyfriend, but had been doing this for many hours. Her boyfriend was not downstairs. There was a surgical nurse, a ward nurse in the room, trying desperately and failing to take OBS from this woman. There was also a one-to-one RMN, a registered mental nurse, who we put for one-to-one observations, who was sit in the corner of the room, basically a little bit exasperated. 2 security guards at the door, who I know quite well, who simply, when they see me arrive, roll their eyes and expect that I have to try and come and unlock this. And then I have a resident in cardiothoracic surgery, who's basically looking at me going, what do I do? Okay. This can be a sort of situation that is probably familiar for many of the clinicians who are in the room, certainly for the psychiatrists who cover any general hospital. And I'm going to come back to it at different points during my talk today. But what I want to do is kind of have a sense of, in order to kind of unlock this really quite complex situation, how would we go about trying to ensure some sense of teamwork? Because when I'm looking at these people, this incredibly disparate group of individuals who cross boundaries of professions and who also cross boundaries of specialities, it's like what we're trying to do is bring together a team with absolutely zero sense of cohesive teamwork that's going on at all, with a little bit of a blame game going on, but also sometimes very aggressive, sometimes quite passively aggressive, and a degree of a sense of no one is basically in charge, and everyone sort of abdicating responsibility for different aspects of care, which ends up being siloed out, as we heard in that video earlier. I'm just going to pause that there because I want to come back to this at different points during the talk. It's not just that kind of high-end, high acuity stuff, obviously, that I deal with. But then we heard this in the video as well. These are some stats from the UK, replicated in Ontario and replicated right across Canada. Large amounts of people suffering from a long-term condition, physical health problems, a significant chunk of people suffering from mental health problems, and then this incredible overlap in the middle, where people end up falling between the cracks because they don't end up being able to be offered safe, high-quality care. The UK, as I'm sure is the case here as well, has a raft of government initiatives and reports which have been written around here. You won't recognize many of these. The most famous one from the UK is there at the bottom, which is called the Francis Report. This has had an enormous impact on the way in which healthcare is looked at in the UK. A report from a failing hospital where the focus was very much on a complete lack of teamwork, a complete lack of a sense of leadership and ownership of care pathways, with this idea that care and compassion was missing from the kind of care pathways that we should be navigating and offering to people. Throughout many of these reports, and there are a litany of them, both those that talk about crossing boundaries in terms of the emergency department. The one down at the bottom there called Future in Mind is a recent one from the Royal College of Pediatrics and Child Health, but also interagency. There's a recent report out from this organization called Embrace, in which the focus very much is on maternal mental health in a perinatal setting. The focus very much is training. Why are we not offering more training? The difficulty that we have is that what you're dealing with here is this gap, this interface, this incredible chasm that exists where the training very easily is offered in the various silos of our professions or the various silos of our specialities as well. But what is it that we can do to try and bridge many of these things? And what I'm going to try and do today is to give you a few examples of how we're attempting to do that, difficult as it is. So the complexity, as I see it in my head, when it comes to the services that we offer patients, is very simply like this. What happens, through no fault of the patient themselves, is that the patient ends up in the wrong place, with the wrong systems to help support that care, at the wrong time, surrounded by people with the wrong skill set or even the wrong knowledge. And in other aspects of my work, as a hospital manager, then I'm looking at the top end of this gradient of wrongness, if you like, around operational policy and around things that we can try and do to help make systems better. But what I'm going to focus on today is this sort of bottom end of this gradient, around kind of skill set and knowledge, and what we can do to try and do something about addressing a whole range of educational needs when you have such a disparate and heterogeneous group of people who are there as a team attempting to provide care for our patients. Just a quick aside, one of the roles that I had, and Latika mentioned many of them, is this one here. There's always an indication that the longer the title that you're given, the less power and the less budget there is associated with it, that's for sure. So this is the longest one I have, which is Chair of the King's Health Partners Academic Health Science Centre, Education Academy, Cross-Country Team, Mind Body Education. Anyway, the main issue with it is that for the first time in our organisation, what we attempted to do was do a scoping exercise over the last year, 18 months. And you're incredibly welcome to have a copy of this. It's available online. And what we're trying to do is identifying responses, educational responses to several things. It's both offering, better physical health training within our mental health settings. It's offering better mental health training within our physical health care settings, within our acute trust. But then this identification that came up out of our scoping, and which we all know in reality is actually the case, which is that this whole different skill set which is required around the interface, around bridging this gap. It's not just about having the knowledge, it's also about having the skills. So, the next part of my talk this afternoon is to try and give you an overview of what we have tried to do, an initiative that we've labelled as Morsey Simulation, which focuses on this thing called mental health simulation. Can I just get a show of hands from the audience? How many people have done a simulation training course? Half-day or a day-long course? Something big. A few people over here, a few people in the middle, so spattering, maybe a quarter of a third of the room or something like that. How many have done a mental health focused simulation training? Is it the same hands? Fewer this time, but still a reasonable number of people. I suppose one of the things that might come out in the debate is what it is that we mean by simulation. And I'm going to use that word lots in the next sort of half hour or so, and certainly as part of the discussion. My training over the last 15 years, one would say, had a lot of simulation associated with it, with all kinds of sort of role plays and pretend sort of situations and all the rest of it, and come and talk about the advantages of that kind of training. What we're doing here is probably on a spectrum with that, but something a little bit different. Rather than me trying to sort of explain in excruciating detail, what I'm going to do is I'm going to show you the first of 3 or 4 videos. This is by far and away the longest, but it's 3.5 minutes long. What it attempts to do is give you an overview. It's our little explainer video, which is available on our website, because most people sort of say, what is it that you do? I have no idea. So what we try and do in 3 minutes is to give you a bit of an overview and give you a bit of a tour of our facility. It was interesting when the video came up earlier, when Benoit was sat down here next to me, he leaned over to Sanjeev and said, "Oh my God, the video, I hadn't realized you were playing it. Thank God I'm wearing a different suit." I'm wearing the same suit. But I just want you to realize that this only dawned on me when your professor of psychiatry said, "Oh my God, thank God, I'm wearing a different suit." Okay, so what I'm now going to do is play this to you.
My name is Sean Cross. I'm one of the consultants in Liaison Psychiatry at the Maudsley. I'm also a teacher, and I'm constantly looking for the best ways to offer better training to all our workforce. Simulation training is about bridging the gap between classroom and real life. We recreate the situations that our workforce would normally have to deal with by making them look, sound, smell, feel like our normal working environment, and then asking people to go in there and play out the situations that they would normally work in.
Maudsley Simulation has grown directly out of this organisation to actually enhance the way in which we and others deliver training and education to frontline staff.
Too often in health services we train in silos, the doctors together, the nurses together. Simulation training offers the opportunity to train as an interprofessional group.
The training sessions deal with issues that range from skilling up staff in de-escalation of challenging situations through to postnatal depression, clinical situations like eating disorders, all the way through to medical deterioration in mental health settings and substance misuse. We don't know of any other mental health trusts that are doing this and looking at simulation that's focused around mental health.
Mannequins are incredibly useful tools. They're really good for simulating medical deterioration. But at the end of the day, what we're interested in doing is actually connecting with a real human being. And that's why we use actors. And we actually train our actors to authentically portray a range of mental health problems.
These people that you're meeting for the first time are in character, so you only know them as the patient, as the relative. That makes it that much more real. It keeps it as real as we possibly can, as real but safe as well.
We record everything using visual and audio equipment, so we use this together with trained facilitators to stimulate really practical learning.
On average, we have 12 participants on each course, so participants arrive first thing in the morning, and then we'll talk them through the basic logistics of the day. 2 participants will go into each scenario. The rest of the participants are watching in real time the scenario as it's happening, and then at the end of each scenario, 2 of the participants come back to the room, and then there's a debriefing.
We aim to tailor our courses to the needs of various organisations that approach us. We have an ethos of trying to be able to deliver here at our training centre or out in the real life environment of the professionals that we are aiming to train. This could be in accident and emergency, this could be in an inpatient psychiatric setting, community settings, and even a coroner's-based inquest court.
The courses aren't just for doctors or nurses. The courses are for anyone and everyone who might be affected or impacted by mental health problems.
There's good evidence that 1 in 4 of us at any point will be impacted by a mental health problem. We think that this kind of training offers the opportunity to learn how to deal and cope with many of the mental health difficulties that people have in an array of settings. We've been running a little over a year, and we've brought through over 1,000 staff from a range of different professions. We've designed, developed and delivered 25 new courses. So we're really ambitious about where we could offer this kind of training going forward.
I definitely think it's training I'll use in my day-to-day job. I think it's very important. I think it should be mandatory.
I wish it was something that can roll out through all the trusts.
It gives a much better sense of what it's like in practice.
Recommend it to not just mental health nurses, but all professions.
To find out more, go to our website, maudseysimulation.com. We'd love to have a conversation with you.
Okay, so that gives a very sort of brief overview, and you get to see me waving my hands as well in a video, as well as kind of on stage. This is if you go to our website, you'll be able to see a whole team of people that we have now. Many of these are clinicians. We have doctors, we have nurses, and we have others as well, including psychologists, who are part of the team, helping us design, deliver, and roll out these courses. And we couldn't do it without this incredible team of people together. And we've been lucky enough to be pump primed by a significant amount of investment as well from our local education commissioners. So I suppose what I want to say, what I want to sort of segue in really from sort of saying, half my week is looking at this complexity and this lack of integration, or this difficulty making integration work in clinical services because of all these difficulties that we're all aware of. And that the educational ask, I think, of the system out there, or the things that we need to do as educators, need to reflect that complexity, and therefore these things need to be quite challenging and difficult to pull together and do. And so what I want to do is give you a little bit of an overview of our thinking around this, just even very briefly, so schematically. Across our just immediate healthcare system, the emergency department, we've got mental health in the community, inpatients, acute hospital, and then our home settings as well. What we're trying to do with all these courses that we're developing is map these courses to these junctures, to these points at which various different professions or various different groups from across different disciplines come together and then try to bring them together, get them around the table. So when you saw everyone coming into that room earlier, that's your group for learning for the day. Now, this brings up all sorts of difficulties and challenges, particularly around what the learning objectives for a particular course like that will be, because you can have a disparate group of people around the table. You can end up having someone who's basically, a first-year resident in psychiatry with a nurse who has 35 years of experience of working across services in a particular area. And so what you need to start asking, I think, is what is the learning objective for this course that is going to meet all their learning and educational needs. And the thing that we're focusing on more and more and more, to the exclusion of virtually everything else, is kind of making this genuinely interprofessional. The way in which we're running our courses are giving space so that people have this immersive, experiential experience of going into these sim labs. That those of you who are residents in the room probably did a lot around with surgery or even some on anesthetics rotations as well, maybe even as an undergrad. But there's very little of this that goes on. What we're wanting is to people walk into that room and go, oh my goodness, it felt real. And then what happens is people start acting, people start behaving in a way that they would do in their normal work. We let it run for 10, 15 minutes, we stop it, and then we bring them back in, and then we start debriefing around many of the skills that we think need to be learned. The focus of a lot of this stuff is the focus of all the stuff that, when I'm wearing my other hat, is usually the outcomes of all the investigations when things go wrong. So the AIs and the SIs, the severe and untoward incidents that come across my desk as a hospital manager, very often are about all these kinds of issues. Communication breakdown. There was no leadership going on. Who was actually in charge? It was complete chaos that was happening. And as a result of that, a bad outcome has happened. Rarely death, sometimes, but very often what you have there is then tip of iceberg with a whole range of things underneath it, with a whole range of near misses that many of you are hospital managers and senior people will be all too familiar with. And these courses, when we run them, will have this focus. We'll get an interprofessional group around the table. It will be experiential being in the room. It will be reflective, and we give people the opportunity to do that reflection through a structured debrief. This brings up a whole interesting conversation that I don't think is best placed with me talking at you, but will probably be part of a discussion, maybe this afternoon, but certainly tomorrow, around the development of competency frameworks and curriculum developments for this gap, this missing thing that there is in the middle. Because obviously, whether you work for a university and you're running a med school or a nursing school, then you have your curriculum, you have your competency frameworks there. The same when you're talking about CPD for many of our hospitals, and the same for our, standard setting organizations in the UK, which would be the Royal Colleges, or the lead providers of training programs if you're going off to be a physician or a surgeon or a psychiatrist. The difficulty that we're dealing with is what is our competency framework for interprofessionalism in mental health, or bridging this gap at the mental-physical interface. And we've started a number of interesting conversations with David and others around this here in Toronto. And I think one of the answers is going to be that these competencies are around these things that are known about and are part of the literature in other areas. That some people call them non-technical skills, some people call them human factors, but these things that are incredibly important for the way in which teams work, the way in which individuals influence one another when two or more human beings come together and dynamics end up being thrown up. Of course, we're talking about leadership and followership and communication, situational awareness, prioritization, all these things that many of you who are educators will be very familiar with. The courses that we've developed, you'll be able to see on the website, are a range of them now. We've got up to around 30. A lot of these are needs-led. A lot of services have come to us and said, we would like a course developed around this. But our most successful focuses have been around these nexuses, these junctions of interprofessionalism. So, for example, perinatal mental health, bringing together health visitors, bringing together obs and gynae trainees, bringing together mental health trainees and primary care workers, because the pathway that someone will go through when they're exhibiting sort of signs and symptoms of a severe mental illness in the perinatal period crosses all this kind of stuff. And rare as the outcomes are, the bad outcomes are for that kind of pathway, when the bad outcome does occur, it's devastating and has a massive ripple effect not only on that individual's family, but these are the things that often make sort of news headlines as well, and make us in services reflect greatly on how it is that all these gaps were not plugged properly. We've run courses with our student body, trying to introduce the notion of interprofessionalism and cross-disciplinary work early. We've had courses focusing in community centres, where we take our cameras out of the centre and go into environments and recreate the spaces for them to work there. And we've even done it in our emergency rooms, both at King's College Hospital, but also out in, if you know South London, in Kent, Surrey and Sussex, where we've gone to a number of emergency departments that have purchased our courses in to offer it to them because of the value that they're seeing in this. But what I want to do over the next 10 minutes or so is go into a couple of courses in a little bit more detail. And these are the courses that we're working with Latica and others at CAMH and University of Toronto to see if we can try and run them over here as well. I came across this just when I was Googling it. It's Swamp People. Apparently this is a new show kind of following the exploits of the Swamp People of Louisiana. Another kind of reality TV show that's kind of taking off. So I don't know, it just kind of stuck it in there. It shows you you give people, any fools, you give them some cameras, and what will happen is you'll start kind of developing a whole range of different things. I'm talking about us rather than the good people of Louisiana. But what I want to focus on today is this notion of mental physical interface. And the reason I had kind of Swamp People up there is for the name of our course. I hated it initially. It was run by a registrar, one of whom was in the video earlier, but swampy. So this is Simulation Workshop at the Mental Physical Interface. This was set up because he regards this as a bit of a kind of, a bit of a sort of sticky no man's land in which it really is quite difficult to offer care. And over the last year, we've also developed a simulation workshop at the mental physical interface for children and young people. We've run these courses on numerous occasions now. I suppose the interesting thing is, if you think about who is actually there around the table, who are your learners? So for our Swampy course, what we have when we run it is we have 3 acute trust nursing staff. We have 3 medical registrars. We have 3 mental health nursing staff. And we have 3 mental health residents. So you have both doctors and nurses, but then you also have cross-disciplinary stuff as well. And we've run it on a number of occasions. Challenging to actually get everyone there and around the table, but when you do, it's extraordinary what you can do. And of course, then when you write the stories, when you write the simulations, what I'm doing is thinking about my day job and dealing with that, moving backwards and forwards across Denmark Hill, moving between the acute trust and the mental health trust. And so just very briefly to give you a couple of the course rundowns, as soon as you start doing this simulation training and get your actors, you just realize that you had a whole series of kind of skills around, film and TV career that was that could have kind of gone if your career had gone in a different direction. But you're able to write these stories so that they can take on a whole range of different challenges. So in the morning of Swampy, we have one course that follows a patient pathway. The guy who you'll see in a couple of minutes' time is a guy called Tunji, a British guy who lives in South London. He has an incredibly unfortunate care pathway, as you might imagine, because what we're wanting to do is everything that can possibly go wrong will go wrong over the course of several hours. And what we're trying to do is, whether we're sending in our medical residents or our psych residents or our acute trust nursing staff or not, what we're wanting to do is to give them a sense when they're in the simulation lab of how you're going to sort of manage this. And of course, what we do with this course is we ramp up the acuity, as you'll see from the video that I'm about to show. Very much replicating that story that I told you right at the very beginning in terms of what is often sort of coming across my desk in a daily way. So, what will happen is, in the room, what we have is one of our actors. All of you saw in the video right at the very beginning, all our actors go on a competency training course, a faculty competency training course as well, which is run by patients and service users who've experienced a wide variety of different illnesses. So we try and get people to be able to portray things like an acute psychotic episode, mania, depression, suicidality, in as accurate a way as possible from past experiences. And so I'm going to show you a couple of these clips. Really, they last less than 1 minute. Just out of context, it will immediately hit you and you go, "Oh my God!" It's kind of, what on earth is going on here? I'll try and deconstruct it a little bit. For those of you who are residents, it might bring a little bit of PTSD back from when you were actually sort of last on call a couple of years ago. But here we have so we've got this is Sandra, who's one of our plants, who's playing the sort of the lead nurse on the orthopedic ward. Here's Tanji, who's one of our actors, and these are two of our course participants. One of them is playing acute trust nursing staff, and the other the psych resident. The first scenario has gone on already. He's presented to the emergency room, acutely psychotic, and with a significant foot injury as a result of jumping off something, as a result of hearing voices. He's been brought up to the orthopedic ward, and the nurse and the doctor have been asked to kind of come along to sort this out. So you get a slightly harassed nurse greeting them as soon as they walk through the door. And of course, what you're looking for is a whole series of things that are happening here. Everybody else who's on the course is next door watching it via live video link, taking notes and looking at what is going on. So there's no one looking at these people directly. There are no prying eyes.
Hi, John. Yeah. I mean, I can see really agitated. And I'm just really worried about all the other patients involved. I mean, they're just, I'm just really concerned. Our descendants, they will show next generation. Praise word of the Lord. Once a year, he's come up to me here, so he's got, he shouldn't really be weight bearing. He needs to be sitting on the bed, and establish the law in Israel. That's what I'm trying to say. I can blatantly see it. There's sinners up in here. It's too blatantly. I can blatantly tell you are a sinner. I can blatantly tell you.
So, you see one of these kind of immersive, even just kind of watching it for a minute, there's just like, boom, 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 boom. There's so much kind of going on here as an educator that I'm wanting to say, hang on, no, let's try to, we need to be able to deconstruct this, and which is why the scenarios themselves last for a relatively short period of time. The debriefs for them afterwards are much longer, but what's going through my head is, who's thinking of their personal safety here? Is anyone actually sort of addressing the patient? We're getting some sort of handover over here, which is going on. Immediately, people are reaching for medication. No one's talking about kind of de-escalation, and there's a whole range of stuff. The kind of thing that, as a clinician, you see happening fairly frequently. What you can do in these courses, as I showed you right at the very beginning, with our explainer video, is that we also use these mannequins. And so the next step of Tanji's rather unfortunate kind of care pathway is that this all gets sorted eventually. We have a nice kind of debrief. Everyone gets some learning about it. And then he moves on. He's transferred across to the acute trust. But over in the acute trust, incredibly difficult. He's been there for a few days because he's non-weight bearing and in a bed and no one's really thinking about this very much. He starts to get a bit of leg pain and he starts to get a bit short of breath. And so what we have now is a situation where, again, patient wrong place, wrong time. Now the patient is over in the mental health trust and is experiencing medical deterioration. We interplay our kind of our mannequins and our actors in this kind of way, and you'll see that further people who are part of the course will now be in where they've been called.
Yes, we will help you. It's having difficulty in breathing. He says that his head is very tight. Have you got any oxygen? Well, I've asked for the emergency bag to come. Okay, let's do some sats. That's right. What's the matter with him, please? So his pulse rate is very, very high. His blood pressure is low. Have we got his... Can't quite get his... We need to get some oxygen, actually. We've got an emergency bag here. Yes, it is. Where's the actual oxygen then? You bottled it. I'm here to help you. Just get that on there, please. Tringy, can you breathe through this? Can we actually sit him up as well, please? Can we sit him up? Does the bed go up? Does it have a way for the bed to go up? I don't think it's right. Oh, there's a raised thing. It doesn't go.
I show you something like that, the chaos that ensues. I remember when I was a resident myself arriving at many of these scenes, and there's, I think too often there's a degree of embarrassment about the kind of, the difficulties that go on, but if we bring it back to the patient constantly, then, these are the kind of things that we need to kind of train for much better. Now we do things like, code whites and, emergency kind of call outs and stuff. And what we're trying to do, what we're attempting to do is integrate some of that learning, some of that systems based testing within a whole day long of interprofessionalism, so that you actually sort of replicate what happens in real life rather than having all this kind of siloed working. What will then go on as part of, we'll experience these scenarios, and then we'll end up having a debrief that goes on. The model that we use, I'm very happy to talk about it if anyone's very interested. It's a relatively standard one, been developed by our colleagues locally, but the idea is that you get people to describe what happened, you then enter into this analysis phase, a much larger facilitated discussion, and then try and bring it forward to some sort of applied thoughts going forward as to how you're going to alter your clinical practice going forward. Obviously, again, out of context, these things don't make a great deal of sense, but I'm just going to show you a short 1-minute video with the same group of people that you saw earlier on, addressing something around after the first of the videos that I showed you.
What did that do to the patient? And, you don't know what would have happened had they not done that, but he got more agitated. So I think, with that personal space thing, that's really difficult, when you're in that scenario. But I think, articulating things like Lloyd said about how the impact on you,
Yeah, that's really useful, because I think I would have always felt like he's so engrossed in his delusions that I wouldn't have thought he'd even listen, but that's like a really useful thing to think about, because and we'd seen earlier that even when he was sort of absorbed in that, but when we talked about pain, he was then engaging. So yeah, I hadn't ever really thought about it.
There's just tons of these nuggets that kind of come out. What you've got here is an acute trust resident. On the other side of the road, unfortunately, you can't see at the bottom of the table, basically saying, well, actually, maybe someone with psychosis also experiences pain. Maybe if we were to address something about the pain, could that have done something about de-escalating? And you get a series of these really very interesting, reflective points that can be taken forward, I think, for slowly chipping away at many of the difficulties around these patient pathways. And so to kind of to try and bring it to some sort of close, what I want to do is talk about a number of things. The challenges that we are seeing, and probably a number of what I have a series of questions rather than sort of definite answers. My job over the last sort of 18 months that we've been running here, having had this injection of cash to basically just do it because it was intrinsically seen as a good thing to do with face validity, it's about getting more stakeholders involved. So it's everyone from the boards of our mental health trust and the acute trust to get people signed up to this incredibly challenging notion of institutional support for interprofessional learning and cross-disciplinary working as well. And it's not working it's not sort of working as a sort of tidal wave, but it is working in very specific ways. Around the perinatal mental health, what we have is a whole series of people now signed up, hundreds of people who are now kind of coming on our courses who've been released from a variety of different institutions, with this course seen as particularly valuable. We're about to do something similar. It seems we're about to unlock a whole problem with interprofessionalism with our colleagues in the child health and pediatric training rotations across London as well. So there are ways in which it's possible not just to see this as overly complex and overly difficult, therefore we can't do anything about it, but you start doing this work, you start seeing the results of some of the initial pilots or the initial courses that we do, and what happens is people will come and people will attend your courses. The cost and developing sustainable income streams is an incredible challenge. These things aren't out of ballpark expensive, but they're far more expensive than an e-learning package. They're far more expensive than me, sat at the front of a room, talking to 20 people, trying to get them to think what they would do in certain circumstances. The question is, do we see the value in basically doing this kind of thing to give them the experiential and reflective learning to be able to sort of take forward? I think that we do, but what we have to do is attempt to prove that. And so what we have is an increasing research agenda. There's a little bit of our initial publication work on the website, which you can go and pick up. And the way in which we're thinking about this in terms of outcomes is a very standard sort of Kirkpatrick model. What we're doing is we're getting that initial sort of level 1 reaction. And you saw from, 3 or 4 of those course participants in the explainer video at the beginning. Even the most nervous people end up going, oh my God, that was brilliant, I loved it, I want to go again. Okay. There's lots of stuff because we happily create a very safe learning environment. When people realize that this is not about embarrassing people, it's not about humiliating them, and it's not about trying to show up any kind of bad practice, people do relax because what they realize is that we're just asking them to be themselves. Okay. So our level 1 reaction tends to be really good. We're also doing a number of pre and post questionnaires around the domains of knowledge, attitude, and confidence. Of course, the next big steps are trying to see what kind of impact this is having in the wider system and the sort of gold standard. Is it making the system safer, higher quality for the patient? Incredibly difficult when you're talking about a complex educational intervention into a complex system to be able to kind of measure the impact of that in any ways. When you ask people, everybody says this will have a great impact on my, future clinical practice. I am now going to manage this thing much better. Great. Okay. That's what they think, which is a great opening start. But what's the proof that that actually continues? We're getting really good evidence that both we get knowledge acquisition, attitude change, and definitely a sense of confidence change, as well, upskilling, people's sense of confidence in dealing with many of these challenging issues. The problem that we've got though is compared with what? Okay. And this was the challenge that Benoit said a few months ago when we first met to talk about this. We have lots of lovely sort of p-values for changes in attitudes, knowledge, and confidence that I can bore you with. Lots of qualitative findings in which people find these things incredibly interesting and valuable. But what we're wanting to do is think about how does this change participants' attitude and confidence over time? Are these changes sustainable? Do they result in kind of sustained changes in practice? Does it work better compared with other kinds of training? This is a real challenge because what you want to do is basically say, can we compare it to other forms of interprofessional cross-disciplinary training? And then you look around and you say, there is none. And actually, if we want to basically set up a cross-disciplinary interprofessional training that isn't SIM, the difficulty is that I have incredible challenges trying to persuade anyone that they would send somebody to something like that. With the SIM component of it, you get from senior managers and people running various directorates a sense that you're going to something. So this is a challenge for us all, and it's going to be a challenge for Latica as well. Does it work in the same way in other systems? And I'm very happy that over the last few days we've made decisions that we're going to pilot our Swampy course over here in Toronto to see if it will work in a similar way in a different system. And does it make a complex system safer and better for patients? Because that has to be the primary goal for all the work that we're involved in. What we're trying to do is a number of different things around that to get this higher level stuff. What we've done is we've taken another one of our courses where we go out into the environments ourselves, but going into a mental health ward this time. And rather than having the cross-disciplinary challenge, we've simply got the interprofessional challenge, which in itself is pretty good. It is pretty big. But here, what we did was we went in every week for over a 6-week period to bring through 100% of the staff, at least once, and a high proportion of the staff 2 or 3 times as well. What we found there was we're looking at significant increases in the number of DATIX incident reports that are going in, and much higher quality in terms of the incidents that are going in. As a medical manager, sort of running a hospital, you have to ask, is that a good thing or a bad thing? I think it's a particularly good thing because what you're doing is you're getting it all out there in the open. We've also done something similar as part of another role that I have, a national role looking at care for patients with mental health problems in the acute trust. We went into a couple of wards very similarly in a acute medical setting. And again, we measure the same things, increases in confidence, and this change in culture of incident reporting that's happening. So I'm very pleased to be able to report that we have a nascent, but hopefully very healthy and growing connection with CAMH and University of Toronto over here. And what I hopefully done is give you a bit of an overview of why I think this is an important subject, what it is that we're doing about it, and then a series of questions about how we might take this forward. And I just want to leave you with the last of the story, going back to that original story of Emma, who was admitted with the pneumothorax. She eventually did have a chest drain put in. She was in hospital for about 4 days altogether, and was transferred across to the mental health unit with no kind of long-lasting sequelae. And so it was a rocky but eventually successful care pathway for her. But the interesting thing about when we went up with the chaos ensuing up there and trying to deal with this, with all these kind of these difficult dynamics that were coming on, one thing that kind of sort of was left with me as I was leaving, and I thought we'd left it reasonably safe, that myself and my intern, who is literally had been about sort of 1 month out of medical school and had gone through our simulation training program. And as we were walking down the corridor, she just sort of leaned over to me and said, "Oh, Dr. Cross, that was amazing. It was just like a simulation." I'd be incredibly happy to speak with you and for you to email me if you have any sort of questions, and it would be even better if we have an ongoing conversation both today and hopefully for many years. But thank you very much indeed.
So you had mentioned, Sean, in your talk a lot around the importance that interprofessional teams play in the design of your simulations. Can you tell us a little bit more about why that was very intentional in terms of your Swampy course for the participants to be from interprofessional backgrounds?
Sure. I mean, I think the very basic answer to that is that we offer services as teams together, and that we should train together. It seems, blindingly obvious. And when we speak to our patient advisory group, it's astounding that people don't do that, that we still kind of work in these silos. So I think complete face validity, really, more than anything else.
And just to sort of expand that thought, are patients and families part of the interprofessional team in terms of your conception of the design?
Okay. So we have an active patient and service user group as part of our hospital network. We are engaged with them as partners in a variety of different ways. As I said, the group that works with us are almost wholly involved in the design and rollout of the faculty training courses that we have for our actors, which is something that we're incredibly proud of. For a variety of the development of a whole range of other courses, we have various different ad hoc input. For example, we're about to launch some work on the development of interprofessional cross-disciplinary training with our local police forces and ambulance services for dealing with mental health crises out of the hospital setting, because these are incredibly challenging and difficult situations, and of course there are huge elephants in the room when it comes to discussions around people acting in the way that they do. Issues around institutional racism, issues around sort of community engagement, and all the rest of it are at the forefront of many people's minds. And there's an obvious opportunity within our debrief and reflective model to be able to address many of these things. And so one of the things that we're going to be doing with those courses is make sure that we have both sort of patient service user engagement and also community engagement in helping us develop the courses.
I believe you have a question through the Twitter feed.
Yes, we do. So the question pertains to massive intentional drug overdose. The question is, medical intervention is critical, but what about preventing another overdose next week?
No, Absolutely, and so this is I suppose bread and butter stuff for my day job, really, which is sort of managing the acute thing. What's the acute needs? What's going through my head as a teacher when I'm on the residency training program for our psychiatrists, what I'm sort of emphasizing, again and again, that what we're wanting to do is, the crisis is often over for this cohort of individuals who present with self-harm in this way. And what we're wanting to do is aim for prevention. Somewhere between 15 and 40% of individuals locally will end up coming back again. And 1% of those who present to our acute trust services will end up taking their own lives in the next year, the vast majority of them via a similar mechanism. And therefore, the psychosocial assessment that occurs at that moment in time is incredibly important. It's not just about, is everything okay now? Are the risks over? What you're needing to do is start talking about, what can you do to prevent, next week, next month, next year, when the same constellation of pressures come on the individual, that individual acts in a different way. I think this brings up a really interesting debate from an educational perspective about how you make your workforce better and more literate around the literature and the knowledge, and also around the skills. Because what you're talking about there is less this kind of high-end, oh my goodness, lots going on, it's all chaos and, multiple people. What you're talking about there is development of a skill set that's much more about psychotherapeutic engagement. And we're experimenting with using the SIM technology, basically having, sort of separated spaces so that people feel as though they don't have 20 pairs of eyes watching them as they try and sort of interview an actor or a patient, to develop courses around psychotherapeutic engagement and psychosocial assessment. It's an obvious thing for us to do. It's a much slower course. It's a course that is probably much more focused on individual skill development rather than interprofessionalism, but it's something that we're also pushing.
We have a question from Dr. Ivan Silver from CAMH.
So I'm interested, and maybe others are too, as to what your simulation center actually looks like, and what necessary technology do you have to actually do the teaching? How mobile is it? Are you able to actually go to the ward to do a simulation? Also, how it connects with the medical school and the traditional simulation center and programs that they offer that maybe don't focus on mental health, and whether you connect or liaise with, are you beginning to connect or liaise with any medical schools simulation program?
Absolutely. Thanks, Simon. I've got an incredible urge to get a marker pen and start drawing out the schematics of our center. Basically, you saw a little bit of it in the explainer video. It's just a series of rooms in one of our hospitals, in which we use some of the space to create, the environments, and we make them look like a hospital sort of bedroom. We've done, community waiting rooms. We've run 3 times now a coroner's inquest court, where we've had our local coroner come in, and we run court for the day, and people have to basically defend evidence on a made-up care pathway that ended in the devastating end of suicide. So you can make that space look whatever you like, and then it's simply another room with a table and live video links looking through into the next spaces. So it's the kind of thing that you can create anywhere with a little bit of investment. I am so jealous about what is about to happen down the road at Queen Street West at CAMH with the new simulation training centre there, and can't wait to see how it gets built and see how you're going to use your much bigger space than we have at the moment for the development of a whole range of courses. But the question about whether people come to your course or whether to go out, I think is an incredibly important one, because, even though you might have just left kind of economic austerity behind in the last week or two, I'm not sure. We in the UK are continuing with very much austere situations in which cash is incredibly difficult to come across. And whilst you're looking for people to be released from their day jobs to come along to a course like this, it's a significant ask. You know, the directors of nursing, directors of our medical directors say, you know, what is it that is happening? So this is what's fueling our whole research agenda. And one of our responses to that is basically, I have this amazing tech team. I've got 3 technicians who basically we've got a startup, and I'm just encouraging them to think in that way. You know, pretend you're at Google, but you can't be paid like you're at Google. And what they're doing is developing a whole range of you know, cameras and audio equipment that we can basically take out in a couple of bags and go out into real life environments. Because I think if you're able to do that, then you're able to start measuring things in a much more interesting way, measuring things in real environments where real teams are working together, rather than having this disparate group of people, however valuable it might be, come along to one of your training course days. As far as our engagement with the various other institutions, I mean, I suppose we are locked into our academic health science network in that we have great partnerships with our Acute Trust Simulation Training Centre, which has been around for about 15 years, focusing very much on medical deterioration. We also have great links with the medical school and the simulation that they do, which to a large extent is, they do a little bit of interprofessional stuff, but it's very much focused on either OSCE practice and summative, you know, end of course assessment exercises, or communication skills. And of course, I'm sure that's replicated in many med schools across the country. We have a separate income stream from that, in that we're trying to offer a range of these interprofessional courses, and our mental health student simulation course that we ran. The problem that we've got is one of scale, in that if you bring 12 people together, if I go to, you know, the head of our medical school and say, we've got this fantastic course that we want to offer, these are the outcomes, I think it's brilliant in terms of interprofessionalism, we've got 480 students per year. Multiply that out by 5 years, you multiply that out by coming to a 12-person course, you realize that, hang on a minute, this is interprofessional. Only 6 medical students kind of come to this course. And what you do is you start to kind of see how the costs can ensue. So at the moment we don't have an answer for that, but we're engaged in the bureaucracy to try and work that out.
Hi. You kind of alluded to this actually in your last answer, but part of the challenge of about kind of abdicated responsibility in these high acuity settings is that you're not sure what other people are going to do. And so I wondered then about simulation training of individuals, of people who don't work in a team regularly, and kind of your kind of mobile simulation would tackle that. But do you know the outcomes of training or having an individual from a certain team do the simulation and then going back to their regular team? Does that make an impact, or should you be kind of bringing real life teams together in simulation?
Yeah, I don't know the answer. I mean, there's face validity to the latter being true in what you're saying, in that what you want is basically to get the people who usually work together to start slipstreaming together and start, you know, if you can start with that team actually having some education focused on the team itself, then, you know, you've got a bit of a result. Trying to measure 12 people coming to a course and then going out into 12 different other environments is an impossible task. What you're talking about is you're measuring, what you're looking at is you're measuring a complex intervention dispersed by 12 into a complex system. If it was done on significant scale and you're looking at perhaps sort of repeated sort of attempts at coming back and having, you know, being very clever in your measurements, then maybe you could start to do something about it. But a one-off course, I think it's probably a bit too much to ask. Would you agree? Would you disagree?
I guess I'm wondering then, like, what is the impact of an individual coming? Should we be looking at training high fidelity teams? Or at least having some standardization of role, so that within the trust, or however within the LIN in Ontario, so that everyone in these situations is aware of what the other person should do, because then we're getting kind of standardization of care, a standard of care that's going to be similar regardless of the setting.
Yeah, I think that's true. And that starts to kind of push towards a competency framework for team working, which is exactly where we need to go to, I think. Because I'm sure it's exactly the same here as it is back home for me in London, in that even before you start looking at the cross-speciality stuff of acute and mental health, every day at 5 p.m., what we do is we throw together teams. We've got about 60 or 70 core residents, some of them, first year, some of them third year. We've got about another 120 nurses who take on a senior role across 5 different sites. And in some combination, we basically, 5 o'clock, boom, they come together. It's a miracle if they actually have a conversation, let alone start to know each other's names or be very clear about roles or kind of start thinking about, pre-planning for any sort of difficulties that might come up. And when you think of the complex stuff that is thrown at someone, someone becoming incredibly challenging verbally or physically, medical deterioration, dealing with a whole variety of other problems, what you need is to build that kind of sense of cohesive teamwork. That's what we want to be able to do, and I think is not too high an aspiration, really. Yeah.
Okay, thank you.
Well, we'll first go to a question that we have on Twitter, and then to the mic.
So the question on Twitter is, how will you include pediatric patients and families in the development of simulation courses for medical psychiatry?
That's a really good question. And we have, so for our Swampy SIP Children and Young People's course, we have a whole series of actors who are currently all over the age of 18, but rather luckily for them, it stands them in very good stead. They look a lot younger. And we tend to use people with that. And so we've simulated adolescent based issues. So a lot around self-harm. There was one that I didn't show today. I chickened out of actually showing it. It was put together by one of our residents. It only lasted a minute, but had one of our actors basically becoming really very angry with the doctor for not letting him go after the audience, after the overdose. But it was just this sort of expletive rant that was just kind of directed at the doctor, which my resident ended up sort of bleeping out. So there's this series of kind of bleeps going on because came to me with this notion of Canada being quite a conservative country, which then ended up kind of and then look at what you all did. But we've been focusing on adolescents rather than young children. But it's something that that we want to experiment with very much. I think there's a whole series of things about trying to keep people very safe in that environment. As far as working with families and carers are concerned, in the sort of hexagon thing that I showed you right at the very beginning, one of our most successful courses now is called Working with Families and Networks, in which we try and bring together a whole series of nurses, residents, and others, and we simulate, patient turning up with their parent, their carer, their aunt, their uncle, and it's all about managing the dynamic in the room, which I think is a really interesting thing to do.
I teach what's called Ask 'em One in our hospital, which is first-year medical students. Again, doing interviewing skill course, and we use simulation actors as patients, and I've been doing it for a long while. And I guess I'm clear about the values of it, much like you've shown. But I'm also becoming clearer and clearer about the limitations of it. And I wonder kind of what your thoughts are about some of those. One I've seen clearly is there's certain things that in the scripts that are avoided. One is culture, ethnicity. That actor was black and he was reading something which might have been religious, and I wonder if that was to be explored, whether the actor was prepared to go there. One actor told me that she once was playing with another actor, and they were the daughters of Mrs. Fusillo, who's going to be put in a nursing home. And so they were being interviewed as to how they felt about it, and they lived in Italy. And this went on, and the issue was, to me, but nobody asked, was both of those actors were black, from New York, as a matter of fact. And I kind of wanted to ask the question, what's it like being in the black community in Naples, and all of that, which doesn't exist. So I wonder about some of the limitations. Do people play gay patients? Do they play ethnic patients? All of that.
Yeah, absolutely. So I suppose two parts to that really. The interesting part, which is the bulk of what you were asking, I'll come to in a second. In terms of the overall limitation, I just want to say I don't think simulation isn't the answer to everything, but it is, I think, an incredibly useful and important part of a portfolio of interventions that the best education establishments and healthcare providers should be offering. But these should be seen on a continuum, with perhaps some e-learning, focusing on mandatory stuff, perhaps some kind of teaching, the good old-fashioned one-on-one apprenticeship model learning is incredibly valuable, and I invest a lot of time in that as well. But it's a intervention rather than the intervention, I think. In terms of the second part of your question, I think this is incredibly important. For me, certainly where I work and where I live, London is one of the most culturally diverse areas of the planet. We have a whole range of challenges around ethnicity and culture. I think it's incumbent on all of us to speak about that and to address it, but it needs to be done in a culturally literate way. The way that we do that means that we need to have an open conversation, and we need to have the right people having that conversation. I think I can bring a certain amount, but at the end of the day, I'm a middle-class white guy. Okay. What I also need is a number of other people who I need to be able to kind of provide a space for people who are very different to me across a whole range of different dynamics, whether that is gender, age, ethnicity, cultural background, all the rest of it, to be able to help this conversation happen. Because without that, you're missing the elephant in the room. And this is going to come up, I think, in a big way with our work around the police. Because I think the notion of institutional racism, whether with the police or with our hospitals, is something that we need to talk about, but it needs to be talked about properly and not just given lip service to. I hope that is a generic enough answer without going too specific for you.
It's a generic answer, but I wondered whether you see simulation as a way of teaching that. Do you have scenarios where those issues come up?
So absolutely. So we use so for example, in the working with families and networks, there's a whole scenario around exclusion of someone because of their ethnic background. Within the Swampy SIP course that we run, we have partner arrangements as well, and we're completely fluid on that front. Depends. We'll say we'll have an actor or an actress, and we end up using whoever the plant is around to be their partner as part of our faculty, and that can be man or woman, doesn't matter, and it can match either way. It's just partner. So these things are all. So we've played that out with partner as a lesbian couple, as a gay couple, and as a straight couple, and rather than necessarily sort of looking at something specific on that front, and we've talked about whether we should be running sim courses specifically targeting that with that as a learning objective. It's an interesting notion. We try and just sort of integrate it into our courses in general.
Thank you.
So unfortunately, we have time just for one more question. So we'll go to the mic here and maybe encourage those who are waiting for a chance to share their questions as part of the Twitter conversation. So I'll invite you. Thanks.
Oh, hi. I'm from the world of family medicine. I think that you answered part of my question because I did want to ask about some of the complementary educational activities that would go with this. So now I have a pretty specific question that I don't think will take long to answer. I've done related work like this around working with families, behavioral medicine, addiction medicine, et cetera. And one of the things I have often thought of how important is to have materials that reinforce getting it right, because it's inevitable when people get into these situations that it's going to be clunky and difficult, and whether or not it's a chance for them to do it again after they've talked it through, or whether there's online learning which kind of shows maybe a best practices example of how people might do it. And I just wonder if you had any comments about that.
Yeah, absolutely. I think this is a really important conversation around what happens in both about what happens in debrief, but also about what it is that we're expecting people to both experience and to learn. We try and move away from this notion of getting it right. Because there are so many variations on getting it right. And so we want to be able to facilitate a conversation about what those variations might be, acknowledging that there are lots of individuals who will have different approaches, sometimes across all those different sort of dynamics that I was talking about just a short while ago, around sort of ethnicity and religion and race and all the rest of it, that people might bring a very different approach to a particular situation. So I don't think that we want to move away from the being a right answer, but I think that at the heart of what you're saying is really important, because if we're not careful, that notion of a facilitated debrief suddenly becomes a rather anything goes sort of conversation. Well, did it feel okay for you? Well, that's okay then. And we need to avoid that very much. So there are certain things that, in terms of the protocols that someone might follow, or the pathway that someone might sort of go after going, or were they given the right milligrammage, or is this the right approach? Is this what we do in this hospital? These kind of sort of accurate ways of approaching a care pathway, as opposed to the conversation around your approach or steps that you might take to change how you would engage with that person going forward. Those two are often sort of dealt with in the dynamic of the debrief.
Right. Okay. Thank you. And I guess the right language might be an example of doing it well.
Yeah.
Because quite often we teach off videos where it shows somebody doing a terrible job, for example, and
absolutely.
that isn't necessarily that helpful.
Yeah, and we tend to do that on the interesting thing is that we tend to use those sort of example videos more on our faculty training than we do in the actual courses that we run. But all sorts of things have thrown up. We usually do interprofessional cross-disciplinary faculty training, so we'll have anaesthetists and all the rest of it coming on our courses. And one of the scenarios that we sort of ask people to critique is my friend and colleague who runs the Acute Trust Simulation Training Centre doing basically a code call to an RTA that had kind of come in, and then asked people to sort of critique it. And the interesting thing is that we had almost an entirely sort of mental health faculty development day, and we showed these things. And usually what happens is there's enormous criticism of number one, where virtually everyone's silent and no one's kind of acknowledging their roles or all the rest of it. And number two, where everyone's sort of speaking, but there's a degree of chaos, but there looks as though there's someone in control. And from the mental health perspective, everyone's like, oh, the first one was really good. It was nice and quiet, we knew what was going. So these things, the context of being able to demonstrate best practice is also incredibly important to understand. Or what you can do is you can end up sort of giving the wrong message to the people around the table as well.